Today we will tackle the management of diabetes according to the new guidelines, as well as tackling the cardiovascular safety in management of diabetes. My colleagues, although hemoglobin A1C targets are converging, good glycemic control is not reached, which means there is a gap between our clinical practice and the optimal practice. That is why the guidelines were put to fulfill the gap between current practice and optimal practice. According to the guidelines, our target for hemoglobin A1C, according to the American Diabetes Association, American Association of Clinical Endocrinologists, and the International Diabetes Federation, hemoglobin A1C, according to the ADA, to be less than 6 individualized goal, less than 7 as a general goal, according to the American Association of Clinical Endocrinologists, to be less than 6.5, IDF 6.5. Very important, the patient are asking me about the optimal preprandial plasma glucose. I am answering that between 90 and 130 preprandial, according to the ADA, less than 110 according to the American Association of Clinical Endocrinologists, as well as the IDF. As regard the postprandial, the ADA to be less than 180, ACE and the IDF to be less than 140. These cut-off points were got from the case control trials and the optimal levels of control of plasma glucose. According to the recent guidelines of American Diabetes Association, we are looking for tight, sustained glycemic control, keeping in our mind the cardiovascular complication among diabetic patients, as well as the risk of hypoglycemia. And the patient is the center of the approach. My target is individualized as regard hemoglobin A1C according to the comorbid condition from which the patient is complaining. So there is individualized target as regard hemoglobin A1C according to the body mass index, the cardiovascular risk, the patient choice, the age, the presence of micro or macrovascular complications, and the duration of diabetes. In front of you, if I am confronted with a young, motivated diabetic patient, I am eagering to lower the hemoglobin A1C to be around 6.5 in comparison to elderly diabetic patient with ischemic heart disease, with a long duration of diabetes, with microvascular and macrovascular complication. I am afraid from hypoglycemia. That is why I am satisfied by hemoglobin A1C between 7.5 and 8. Actually, my colleagues, around 2/3 of diabetic patients do not achieve target hemoglobin A1C. And our scenario in the management of diabetes, all of us know that diabetes mellitus is a progressive disease. And according to the progressive nature of the disease, we are escalating our management. At the time of diagnosis, we are applying diet, exercise, and metformin as oral monotherapy. The disease is deteriorating. I am escalating my medication by combination of medication. Then the patient is still, there is some sort of deterioration. I will add basal insulin. Then I will add complete insulinization for the patient as a basal bolus according to the progressive nature. This slide in front of you addresses the protocol of management in type 2 diabetes in 2015 according to the American Diabetes Association. When we diagnose newly diagnosed patient with diabetes, I should apply intensive lifestyle modification plus metformin in the therapeutic dose 2 grams, if not contraindicated. Within 3 months, if the patient is not reaching my target individualized hemoglobin A1C as I have explained before, I will put one from each 6 boxes in the first line therapy, and in front of you we can see sulfonylurea, TZDs, DPP4 inhibitors, GLP-1 analog, sodium glucose transporter inhibitors, or insulin. And I will wait for 3 months. If the patient on the combination therapy is controlled and reached the target hemoglobin A1C, it is well and good. I will keep on. If not well controlled, I will add in a complementary manner from different boxes from the second line in order to reach the target hemoglobin A1C, and so on until reaching the target hemoglobin A1C. We have said that diabetes is a progressive disease. Diabetes carries a cardiovascular risk to the diabetic patient, and again, some of the medications of the anti-diabetic medication increases the cardiovascular risk among diabetics. As you see in front of you in this slide, diabetes carries a direct risk for the diabetic patient by upregulating the cardiovascular risk directly, and some of the medications through weight gain, obesity, or induction of hypoglycemia can increase the cardiovascular risk. Let us revise our targets by medication in which we are applying to treat diabetes. We can use, as in front of you, biguanides like metformin, which decreases the hepatic glucose production and increases glucose uptake by peripheral tissues, sulfonylurea, which tickle and stimulate the beta cell to release insulin, a secretagogue, and we have meglitinides, which act in the same way like sulfonylurea. We have alpha-glucosidase inhibitor, which inhibits the absorption of glucose. We have TZDs, which act as insulin sensitizers in the body. We have the GLP-1 analog, which acts in a glucose-dependent manner, stimulating release of insulin and suppression of glucagon. And we have the DPP4 inhibitors, which prevent the destruction of GLP-1 and upregulating the diminished level of GLP-1, which is already diminished among diabetics, upregulating insulin release and suppression of glucose. And recently, we have sodium glucose transporter 2 inhibitors, which inhibit the reabsorption of filtered glucose by the kidney, so we lose more glucose in the urine, lowering the plasma glucose. This another alternative 2015 guidelines, the American Association of Clinical Endocrinologists, which tackle the management of diabetes according to the presenting hemoglobin A1C. If I am confronted with a newly diagnosed diabetic patient with hemoglobin A1C less than 7.5, I feel free to apply from the first column any medication as a monotherapy, either sulfonylurea, DPP4 inhibitor, GLP-1 analog. If I am confronted with a newly diagnosed patient with hemoglobin A1C above 7.5, I will use double therapy from the start in order to remove the glucotoxicity and to reach the intensive tight control as early as possible. Before, we have said that in the management of diabetes, the lower is the better, which now is not true. Now we are saying the earlier is the better in the management of diabetes for fear of hypoglycemia from the studies which we have got, like the Accord trial, in which we tried to control the level of blood glucose as lower as we can, and we find the mortality was increased among certain groups of patients due to hypoglycemia. According to the American Association of Clinical Endocrinologists, if we are confronted with a newly diagnosed diabetic patient with hemoglobin A1C above 9 without symptoms, I can use double or triple therapy from the start, or if with symptoms due to hyperglycemia, we can start with insulin from the first moment. This slides in front of you makes some differentiation between the positive results and the negative results among different groups of medication we can find as regard the increment of body weight. The DPP-4 inhibitor and GLP-1 analog are taking the upper hand as a good choice among diabetic obese patients, because they will not induce obesity more. If I am confronted with a diabetic patient and I am afraid from hypoglycemia, suppose this patient have some sort of ischemic heart disease or elderly diabetic patient who is living alone, and I am afraid from hypoglycemia, again, I will choose the molecules which are gentle in the management as regard the risk of hypoglycemia, like DPP-4 inhibitor and GLP-1 analog. If I am confronted with a patient with the metabolic syndrome and I suspect that there is some sort of insulin resistance, for sure I will tackle the insulin resistance by choosing TZDs. And if I am confronted with a patient whom the fasting plasma glucose is high, I will choose the molecules which acting and tackling the fasting plasma glucose, like alpha carbose and other prandial insulins, which are targeting the postprandial hyperglycemia, basal insulins, which are tackling the fasting plasma glucose. According to the scenario, I will play and choose from the different molecules according to which of them targeting the fasting and which are targeting the postprandial. I have said that from the American Diabetes Association guidelines, we are applying lifestyle modification plus metformin, and if within 3 months the patient is not well controlled, I will choose one of the 6 boxes of the first line, which are sulfonylurea, DPP-4 inhibitor, TZDs, GLP-1 analog, sodium glucose transporter inhibitor, or insulin. This study in front of you, which is called What Next After Metformin, helps the clinician to choose which molecule for whom patient. Let us go through this study together, and we can see as regard all-cause mortalities by choosing the second medication plus metformin. As regard bioglitazone had decreased the all-cause mortality in front of you, and DPP-4 inhibitor had decreased the all-cause mortality in comparison to the first generation sulfonylurea. As regard major acute coronary events again. TZDs or pioglitazone had decreased the incidence of these cardiovascular effects. DPP-4 inhibitor have a beneficial effect in comparison to old generation sulfonylurea. As regard the myocardial infarction, the same results in front of you. DPP-4 inhibitor and TZDs have a favorable effect on diabetic patient as regard the induction of myocardial infarction. Again, it was bad with first generation sulfonylurea. The same story as regard stroke, even the carcinogenesis. This medication, TZDs and DPP-4 inhibitor, had decreased the incidence of some sorts of cancer among diabetic patients, and the combined endpoints were in favor for the TZDs and the DPP-4 inhibitor in comparison to the first generation sulfonylurea. We have said that the recent guidelines addresses as regard the newly diagnosed diabetic patient to apply lifestyle modification plus metformin 2 grams if not contraindicated. Why metformin? Why metformin was put as a first line therapy among all of the guidelines? Let us see some of the privilege of this molecule. Metformin is tackling the insulin resistance among diabetic patients. It tackles dysglycemia, dyslipidemia, obesity, hypertension, as well as hypercoagulation. All of us know that diabetic patients are in a state of thrombophilia and at increased risk for thrombosis. When we are using a medication which lowers the plasma glucose and decreases the liability for thrombosis, we are gaining more benefit. Metformin decreases the hepatic glucose output, so it decreases glucose production, decreases gluconeogenesis, decreases glycogenolysis, and the upregulation of glycogen synthesis. So the net result is decrement in the hepatic glucose output, so it decreases the blood glucose. Also, it helps in uptake of glucose in the peripheral tissues, whether the muscles or the adipose cells, so this is the mechanism of action. Let us see together how insulin signal transduction occurs. When insulin is released from the beta cells, it becomes attached to the insulin receptor, then some trafficking intracellular occur inside the cell, leads to opening of GLUT4, which is the gate through which glucose enters from periphery inside the cell. These are the trafficking system. This is the GLUT4 open for entry of glucose. Trafficking system also, after stimulation of the insulin receptors, leads to upregulation of nitric oxide synthetase, which is a vasodilator to the blood vessel, and this is beneficial among diabetic patients. And this is the metabolic pathway. When we are confronted with a patient with insulin resistance, the metabolic pathway is blocked and the oncogenic pathway is upregulated and leads to the relation between elevation of glucose and the oncogenesis and inflammation. By using TZDs, they decrease the insulin resistance, augment the trafficking system inside the cell, so it enhances the metabolic pathway and it decreases the oncogenic and inflammatory pathway. I have said that some medication, and we have seen in the study what comes after metformin, that first generation sulfonylurea had increased the risk for myocardial infarction and ischemic heart disease. Let me explain how. The mechanism of action of sulfonylurea. Sulfonylurea binds to sulfonylurea receptor 1 on the beta cell, closes the ATP sensitive potassium channel. Closing of the ATP sensitive potassium channel increases action potential, leads to opening of calcium channel. Calcium goes inside the beta cell, strikes the granules and the vesicles to release insulin. This is the mechanism of action of sulfonylurea by binding to sulfonylurea receptor 1. We have another sulfonylurea receptor 2 is present in the myocardium. If I am using a sulfonylurea which does not discriminate between sulfonylurea receptor 1 in the pancreas and the sulfonylurea receptor 2 in the myocardium, it will close the potassium channel, ATP-dependent potassium channel, which are very important in protection against ischemic heart disease. So, if I use sulfonylurea, which is non-specific and closes the potassium channel in the myocardium, it will deprive the diabetic patient from a protective mechanism against ischemic heart disease, which is called ischemic preconditioning reflex. What is ischemic preconditioning reflex? In Arabic بنقول إن الضربات التي لا تقسم الظهر تقوي. The hits or kicks which does not break the backbone, it will strengthen it. The same rule is applied here. When the ischemic patient is subjected to recurrent trivial attacks of myocardial ischemia, the myocardium becomes resistant against lethal attacks of ischemia. This property is dependent on the ATP potassium channel to be open. If I use a sulfonylurea, which closes the ATP-dependent potassium channel, this protective mechanism will no longer acting in the myocardium, putting the diabetic patient at increased myocardial infarction. In front of you, you can find in a case of no ischemic preconditioning reflex, you can find the size of myocardial infarction in dark line is greater to another person in which the ischemic preconditioning reflex is intact. And this is the same picture in diabetic patient using the first generation sulfonylurea, the myocardial infarct size is increased. Let us go through the GLP-1, glucagon-like peptide 1. What is the story of that? Actually, my colleagues, when we eat food, the nutrients come in contact with the intestinal mucosa, releasing some of the gut hormones, which are called the incretins. Incretins stimulate the release of insulin through upregulation of GLP-1 and GIP. They help the pancreas to release more insulin and suppress the glucagon. That is why they are beneficial in combating the elevation of plasma glucose. We have found among diabetics that GLP-1 is diminished and its actual half-life in the body, either in the normal or diabetic patient, only 2 minutes. By using certain medication which prevent the destruction of GLP-1, which are DPP-4 inhibitor, which inhibit the enzyme responsible for destruction of GLP-1, I can upregulate the level of GLP-1 among diabetic patients, releasing more insulin and lowering glucagon with the end result of lowering of plasma glucose. Let us see in this slide the beneficial effects of GLP-1. It acts on the beta cell, enhances in a glucose-dependent manner insulin release, and decreases the apoptosis of the beta cell and helps regeneration of beta cells among animal studies. So it decreases the beta cell workload and suppresses the postprandial glucagon level, and on the liver it decreases the hepatic glucose output by downward regulation of glucagon. It has a beneficial effect on the motility of GIT and in the stomach. It helps to regulate gastric emptying, helping the patient to feel satiety and becomes more adherent to the diabetic diet through action of the stomach, and it promotes the satiety by reducing the center of appetite in the brain. GLP-1 improves beta cell survival and beta cell mass through modulation of endoplasmic reticulum stress, increase the level of cyclic AMP, reduce the expression and reduce the activation of effector caspases, decreased glucolipotoxicity, which are lethal to the pancreatic cells. So we are gaining the benefits of adaptation to metabolic and cellular stress, prevention of beta cell apoptosis and upregulation of proliferation, upregulation and the expression of glucokinase and GLUT2, which are glucose receptor on the surface of the cell, and increase the mitotic activities among beta cell of pancreas. The effects of GLP-1 on the hepatoportal sensors. The L cells in the gut release GLP-1 acting on the portal circulation, and the sensor for GLUT2 receptor and GLP-1 receptor stimulates glucose utilization and decreases the glucose in the peripheral circulation, leads to removal of glucotoxicity on the beta cells. Let us go through another modality, new modality in the management of diabetes and the role of the kidney in the management of diabetes. Actually, my colleagues, the kidney has 3 key functions in glucose balance: glucose production through gluconeogenesis, glucose utilization. The kidney is active tissue and consumes glucose, as well as glucose filtration and reabsorption. Sodium glucose transporter 2 is a new therapeutic target that can help lower blood glucose levels by inhibiting renal glucose uptake. Glucose is filtered through the glomerulus. There is some sort of reabsorption of glucose in the proximal and the distal convoluted tubule. And sodium glucose transporter 2 is the enzyme responsible for the reabsorption of glucose through the kidney. So, if I inhibit this enzyme, I will prevent the reabsorption of glucose. Glucose will be lost in the urine. It will lower plasma glucose, and it has another beneficial effect. Glucose goes in the urine and takes water, so it tackles the hypervolemia which is present among diabetics, lower the blood pressure. Loss of calories leads to reduction in the body weight. These are some of the beneficial effects of the newly molecules which inhibit the sodium glucose transporter 2 in the kidney. So, Sodium glucose transporter 2 inhibitors act in insulin-independent mechanism of action, leads to reduction in the fasting, postprandial hemoglobin A1C with loss of excess calories in the urine, resulting in weight loss and reduction in the blood pressure. Let me finish my talk today with you with the new classes in the pipeline in the management of diabetes. We have expecting the long-acting GLP-1 receptor agonist, which can be taken once weekly, and we are hoping to be once monthly. We are expecting the dual and the pan-PPAR agonist, which tackling the insulin resistance as well as the dyslipidemia in the same time. We are expecting 11 hydroxysteroid dehydrogenase 1 inhibitor, which is related to the cortisone and the hormones which are antagonizing the insulin, fructose 1,6 biphosphatase inhibitor, glucokinase activators, G-protein coupled receptors, protein tyrosine phosphatase 1B inhibitor, acetyl-CoA carboxylase 1 and 2 inhibitors, glucagon receptor antagonist, salicylate derivatives, immunomodulatory drugs. And actually, let me finish my talk, my colleagues, by a sentence had been said by Professor Smith. He had said that we seemed that we have won the battle in the management of diabetes, but we are still losing the war in the management of diabetes. And thank you so much.